Hi, thanks for tuning in. My name's Peter Cram, and I am an Associate Professor of General Internal Medicine and Division Director for General Medicine at the University of Iowa, Carver College of Medicine in Iowa City, Iowa. I'm talking today about a paper we have in the April issue of Mayo Clinic Proceedings. The title of our article is Total Knee Arthroplasty Outcomes in Top-Ranked and Non-Top-Ranked Orthopedic Hospitals. By way of background, there's a great deal of attention given to the U.S. News and World Report rankings of America's best hospitals. These rankings are used by hospitals extensively for marketing purposes. They're also used by patients to make decisions about where to get their care. And while there's been a fair amount of research looking at whether the top-ranked cardiovascular hospitals have improved patient outcomes for cardiovascular disease, there's really not been a lot of work looking at orthopedics. In particular, it's unclear whether these top-ranked hospitals in orthopedics also have better than average or excellent outcomes in orthopedic surgery. So with that background, we set out to examine primary total knee arthroplasty outcomes in top-ranked and non-top-ranked orthopedic hospitals. So what we did is we used Medicare Part A or inpatient claims to identify patients who underwent primary knee arthroplasty in three groups of hospitals: top-ranked orthopedic hospitals, non-top-ranked hospitals that were eligible for the U.S. News rankings, and then a third group, which were hospitals that were ineligible for the U.S. News rankings because they were often too small or had too low a volume. So what we found was that there really was very little difference in the outcomes between the three groups of hospitals. In particular, we found that complication rates, things like myocardial infarction, bleeding, infection, that rates of complications were similar in all three groups of hospitals once you adjusted for or accounted for differences among the patients treated in the three different groups of hospitals. In other words, when you did an apples-to-apples comparison, the top-ranked hospitals, they really looked a lot like the other hospitals, and they did not seem to have improved outcomes. Likewise, we found that the top-ranked hospitals did not have shorter hospital length of stay. They didn't have lower 30-day readmission rates. Our total sample consisted of almost 65,000 patients who underwent primary knee arthroplasty procedures in 2006 in any one of 817 hospitals. These hospitals included 48 top-ranked hospitals, 288 non-top-ranked competing orthopedic hospitals, and 481 hospitals that were not considered eligible for the U.S. News rankings. We compared patient demographics and comorbidity for the patients undergoing primary knee arthroplasty in each of the three groups of hospitals. We then compared several different outcomes across these three different groups of hospitals, including rates of mortality, deep vein thrombosis, pulmonary embolism, wound infection, postoperative myocardial infarction, and sepsis occurring within 30 days of the index surgery. We compared rates of a composite outcome in each of the three groups of hospitals, with the composite representing a patient who had one or more of these individual complications. In addition, we compared several other outcomes that might be of interest, including hospital length of stay, 30-day readmission rates, and total hospital costs using cost-to-charge ratios, again, across the three different groups of hospitals. We compared the three groups of hospitals with regards to both unadjusted outcomes, but also in adjusted outcomes. In the adjusted outcomes, we accounted for differences in the severity and complexity of the patients treated in each of the three different groups of hospitals. We found very little difference in any of the outcomes in either the unadjusted or the adjusted outcomes across the three different groups of hospitals. In our unadjusted analyses, which did not account for differences in patient case mix or severity, we actually found a somewhat higher rate of adverse outcomes in the top-ranked hospitals, particularly when compared to the ineligible hospitals. For example, we found that the percentage of patients experiencing one or more adverse outcomes was 4.3% for the top-ranked hospitals, 4.1% for the competing non-top-ranked hospitals, and 3.3% for hospitals that were ineligible for the rankings. This means that in the unadjusted analyses, outcomes actually appeared slightly worse in the top-ranked hospitals, which is somewhat counterintuitive. Looking at all-cause 30-day readmission rates, we found that readmission rates were quite similar across the three groups of hospitals. The 30-day readmission rate for the top-ranked hospitals was 8.2%, 8.4% in the non-top-ranked competitor hospitals, and 8.1% in the hospitals ineligible for the U.S. News rankings. Again, here suggesting little difference in readmission rates. We found very little difference in hospital length of stay across the three groups of hospitals, with a mean length of stay of approximately 3.7 days for patients in each of the three hospital groups. In additional analyses that adjusted for differences in patient case mix and demographics across the three groups, we actually found that there was essentially no difference in either the composite outcome, length of stay, or readmission rates across the three groups of hospitals. In other words, while the top-ranked hospitals appeared to have somewhat worse outcomes in the unadjusted analyses, once you took into account the differences in the patients treated in the top-ranked and non-top-ranked hospitals, we found that there was no significant difference, meaning that all of the hospitals appeared roughly equivalent in terms of their outcomes. Now, there are a number of caveats that need to be taken into consideration when you think about our study. The first and probably biggest one is that we were using Medicare administrative data. Therefore, we lacked access to a lot of the patient-centered outcomes, which one might consider important. In particular, we didn't have measures for patient satisfaction. We didn't have data looking at health-related quality of life. We lacked data to compare the functional status, or how far patients could walk, or their symptom relief after total knee arthroplasty. So, there clearly are important limitations in our study. So to conclude, in an analysis of Medicare Part A data, we found little evidence that top-ranked hospitals had significantly better outcomes in joint arthroplasty using Medicare administrative data. The take-home message for patients and providers might be is that there are good hospitals across the country, and that limiting yourself to the top-ranked hospitals is not always necessary. Thank you.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.